Dear viewers, welcome you all to our new show, Orthopedic Solution Academy. And today our topic is basics of shoulder MRI. We will discuss about various type of shoulder problems and their latest treatments, such as arthroscopy and also trauma management. And we have two learned academic experts with us. One is a highly academic person from India, that is Dr. Rajiv Brahman sir, and who is very much popular in our country, Bangladesh also. I would like to request Dr. Rajiv Brahman sir to join with us. Sir. Welcome to our show, Orthopedic Solution Academy.
Thank you so much.
Thank you very much, sir, for joining with us. Dear viewers, today we have another learned speaker from Bangladesh, the pioneer shoulder arthroscopic surgeon in Bangladesh, that is Dr. G.M. Jahangir sir, the associate professor of NITO. I would like to request Dr. G.M. Jahangir sir to join with us.
Thank you, Dr. Ashraf, and thank you, my friend Dr. Rajiv Brahman from India.
Thank you very much, sir, for joining with us. Dear viewers, today our topic is the basics of shoulder MRI. And now I would like to request our honorable speaker, Dr. G.M. Jahangir sir, to share his screen with us. Sir, would you please share your screen with us?
Thank you. Can you see my screen?
Not yet, sir.
Okay. Can you hear my screen?
Yes, sir.
Can you see?
Yes, sir. Yes, sir.
Okay.
We can hear you properly and we can see your screen absolutely fine, sir.
Very good evening. I am Dr. G.M. Jahangir from Bangladesh. This program is dedicated to my orthopedic surgeon, my orthopedic fellows, and my resident doctors who are obtaining their post-graduation degree. And I thanks to this arranging for this program who are helping with us, Dr. Rajiv Raman, my friend from India, and Dr. Tanvish Ashraf, who is the moderator of this program, and as well as the RajTV. Actually, this program is my only for orthopedic surgeon, as because we are not the radiologist. We can view our program in favor to treat the patient, and we are the advantage of a radiologist because we can hear the history from the patient, we can examine the shoulder of the patient, as well as we can see the X-ray film. So we can easily detect our targeting pathology from the X-ray film. So I am now starting the basic anatomy, which are recognize the structure in MRI of shoulder. So our main topic, shoulder MRI reading, and which includes in this talk is applied MRI anatomy of shoulder. Before going to the next slide, we just remember the three planes which are required for the films like coronal oblique, sagittal oblique, and axial plane. And we must know the three film, coronal, sagittal, and axial to get the information from the MRI film. There is coronal oblique. This lies parallel to the tendon of the supraspinatus muscle, going from posterior to the anterior shoulder. That means the coronal oblique plane, which film are slices from front to back of the shoulder. And next, sagittal oblique plane, slice perpendicular to the supraspinatus muscle going from head of the humerus to the scapula. That means the sagittal plane, it starts from the lateral side and going to the medial. I mean, greater tuberosity of the humerus to the scapular neck. This is sagittal oblique plane. And next plane, axial plane, makes cross section of the shoulder from top to bottom. That means the axial cut start at the level of the supraspinatus and gradually it goes down. So we may remember it. Three plane, coronal oblique, sagittal, and axial. So we just remember three. And this shoulder MRI sequence, which already I have mentioned, that is coronal oblique. And you can see this type of film when you see, this is coronal oblique, and this sagittal oblique, this type of film, and next one, the axial cut. All this image we must remember, always remember, that is coronal oblique, sagittal oblique, and axial cut. And this may be T1, T2, or fat suppressed, STF, PDS, and sagittal oblique T2 fat suppressed, and axial T1 and fat suppressed. But we do not remember, only we know the three cut, that is coronal, that is sagittal, and axial. I have already mentioned, as we are the orthopedic surgeon, so our knowledge should be limited to detect the only pathology from the three type of plane, coronal oblique, sagittal, and axial. Next, sequence of shoulder. This also we remember, that is T1 weight image, T2 weight image, and proton density, PDS. T1 weight image, everybody know that is fats and bone marrow produce high signal. That means white, whereas ligament, cartilage, and fluid produce low signal, which is in black in MRI film. And T2 weight image, this is actually detects the pathology, like ligaments, cartilage, and fluid produce high signal white, and bone marrow produces a low signal black when there is pathology is there. And proton density image, we can enhance the tissue with the high protein density like fatty bone marrow, hyaline cartilage, and muscles. So we only know T1, T2, and protein density images, where we detect the normal as well as pathological one. In coronal oblique, I have already mentioned this starts parallel to the plane of the supraspinatus muscle, and it is always cut section from anterior to posterior. You can see here, this is the supraspinatus muscle, and always it's parallel to this coronal oblique, parallel to the supraspinatus muscle axis. And there are three important cut section from coronal oblique, like this anterior cut, and next one middle cut, and next one the posterior cut. And with these three cut, we can see all the normal as well as abnormal things within the shoulder joint from coronal oblique. And what are see from the coronal oblique, which run parallel to the plane of supraspinatus, like subscapularis tendon. In this film, we can see this is the subscapularis muscle, and this is subscapularis tendon, supraspinatus and anterior infraspinatus tendon. This film, you can see this is infraspinatus tendon, supraspinatus tendon, and supraspinatus muscle. And you can see this is AC joint, and any fracture like GT fracture or the greater tuberous fracture, you can see from here. And subacromion, subdeltoid bursa. This is acromion and subacromion and subdeltoid bursa. When present, we can see from here this. And from this coronal oblique plane, we can easily detect the superior and inferior labrum. Like this is labrum is always in triangular in cut section. We can see this is triangular area superior, and this is the inferior. And also this is superior and inferior labrum. Also from the posterior film, superior and inferior film. And we can see from the biceps tendon from this here. Biceps tendon, it arises from the supraglenoid tubercle, and it's come by 3-2 here the long head of bicep tendon from this film, like, and also from here this is the short head come this. And any lesion like bony bankard or heel sac lesion, we can see this is bony bankard when there is a bankard lesion in the from the glenoid, from here in the glenoid. Always it is the middle part, at the anterior-inferior part, we can see the bankard lesion. And when the heel sac lesion, we can see also. And also heel sac lesion, we can see from the axial cut more easily. And can also cartilage at this articular cartilage from here, this is articular cartilage, we can detect from this coronal oblique plane. Next card is sagittal oblique. We have already seen plane is perpendicular to the coronal oblique. Coronal oblique and parallel to the glenoid face and cover from the scapular neck medially through the gator tuberosity laterally. That means sagittal card, this card, and it starts from the lateral side and goes to the medially up to the scapular neck. And this card maybe start from here up to middle, ultimately scapular neck. This type of card we can see, the sagittal card. If we put you can see a total film of a MRI film of the sagittal card, and it started from the lateral, and that means at the gator tuberosity of the humerus, ultimately cut down, and then comes to the at the humeral head, then up to come to the glenoid fossa, and last film you can see the at the glenoid neck level. That means it starts from lateral and end at the scapular neck. So all the structure in between gator tuberosity to the scapular neck, you can see the MRI film, all the structure as like normal, as the anatomical variant, as well as the pathological one. Sagittal oblique. So what are we can see from the sagittal oblique card, like rotator cuff tendon and GT flexor. In this film, we can see that if we think it is posterior, it is anterior, that is superior, then with this level, we can see the supraspinatus tendon, that is infraspinatus tendon, this is here is a teres minor tendon. In above, you can see this is the acromion, and this is here it is biceps tendon, bicipital group, bicep tendon, and this is subscapularis tendon. So all important rotator cuff tendons as well as acromion and all we can see this sagittal plane card. Also we can see also bony bankard, like if there is any bankard lesion from this glenoid fossa, bony bankard, rotator cuff. Types of acromion, this is variety of acromion you can see from here as subcoracoid bursa and subscapular recess. From this here we can see from the sagittal card. Next plane film, we can also see more about the structure, anatomic, variant, as well as pathological from the sagittal oblique card. In this film, we can see the types of acromion, like this is a normal or flat type acromion. In this film, you can see there is curved acromion, and in this is a hooked acromion. This is hook variety, hook acromion, and next one, this is type 4, that is convex variety of acromion. This is the anatomic variant of acromion. Easily we can detect from the MRI in sagittal cut section. And next cut is axial cut. Axial cut we have already mentioned. It's start at the level of the supraspinatus and it goes down from above to downward. And that you can this figure you can see that is the acromion, this is clavicle and supraspinatus. So this is from this level it is start and goes downward, and this muscle is supraspinatus muscle cut. So easily we can detect any pathology or muscle belly or any abnormality from the axial cut, and we can see more from the axial cut. And when we put a total film, MRI film or axial cut, at the level of the supraspinatus muscle, that is acromion and clavicle, up to goes down and to the scapula, up to the humeral head. So from above down, we can see the labrum anterior-posterior. In this film, we can see the labrum. This is anterior and posterior. It is triangular in labrum. And glenohumeral ligament. From this we can see medial and superior glenohumeral ligament in the film. And any bankard lesion, we can see from here, from the glenoid. And biceps tendon, we can see, this is the biceps tendon, we can see from here. And when there is this cut, is at the level of the coracoid, we can see the heel sac lesion at the level of at the coracoid level, just opposite the bicipital group or bicep tendon. And subscapular tear and teres minor tendon and cartilage, all things we can see from this axial cut when it is cutting from above to down in the sequentially. And this is individual cut of it. I think it is a bit above the level of cut section. If it is anteriorly, you can see that is anterior labrum, triangular in cut section, and also posterior labrum. Here we can see that is supraspinatus tendon, the biceps tendon, and this is the subscapularis tendon. So this is a coracoid. This is a coracoid glenoid, and here is superior glenohumeral ligament. And this tendon is infraspinatus tendon, and here is, you can see the teres minor tendon. So this is infraspinatus muscle, and this is teres minor muscle. All these normal and applied anatomical variant we can see from this slide. And here it is seen that is suprascapular nerve and vessel at the suprascapular group. This is the axial cut. And more axial, when it is cut a bit down, we can see there is a bicep tendon group, that is bicipital group, and infraspinatus tendon. Here they do a bit down. So in this situation, we cannot see the supraspinatus tendon, but we can see the infraspinatus tendon. Here there is posterior labrum, that is the anterior labrum, and medial glenohumeral ligament, subscapular bursa, and suprascapular tendon from the anterior side. And in this position, sometimes we confuse with there is a white high signal. It may be that is heel sac. No, but heel sac level a bit anterior at the level of the coracoid. So we can understand from this situation that it is not a heel sac lesion. There is some plating at the lower part of the head. And next slide of the axial image, you can see, I remember this is a bit lower. There is only tendon come to us, that is teres minor tendon. So this is not infraspinatus, this is not supraspinatus. Only teres minor tendon come here, and this is bicep tendon, and it is subscapular tendon is still there, and medial glenohumeral ligament. This is posterior labrum, and here is a triangular anterior labrum, glenoid, and this is articular cartilage muscle here. So when there is its cut above downwards, there is variety of anatomical, normal anatomy, as well as pathology we can see. So a bit more later, we can see that is all this structure in this field we can form the axial cut. You like all things, you the coracoid process. In this field, you can see the coracoid process, glenohumeral ligament, tendon of the subscapularis. This is tendon of the head of the biceps brachii muscle. This is neck of the humerus, humeral head, glenoid fossa. This is glenoid fossa, tendon of teres minor. Here, tendon of teres minor, glenohumeral scapula, and deltoid muscle, this one, and subscapular nerve here, and suprascapular muscle, infraspinatus muscle. This is subscapularis muscle. This is the all structure from this view, axial cut we can see from this view. So this axial cut is very important to detect the various anatomy. And this is the end plate, and thanks for attention, dear my friends, colleagues, and my friends and moderator and Dr. Rajiv Raman. Thank you all.
Thank you very much, sir, for your nice and excellent presentation. And I think all the young surgeons will be benefited from your presentation. Now, I would like to request our honorable international faculty, Dr. Rajiv Raman, sir, to share his knowledge regarding the basics of MRI of shoulder. Dr. Rajiv Raman, sir, would you please share your knowledge with us?
Yes. So thank you so much. And it's indeed pleasure to join this meeting. And I would like to thank Tanveer and Dr. Jahangir for choosing this basic topic of reading the basic of shoulder MRI. I think most important point is whenever you are planning to read an MRI, it's a clinical, radiological, and anatomical assessment. First, examine your patient clinically, then see your patient at what anatomical location your patient is having real pathology, and then order your MRI. Try to correlate your MRI finding with your clinical finding. As per sometime what happens, you see there will be fluid in the bicipital group, but the patient don't have a speed test positive. He don't have tenderness in the bicep. So small amount of attrition of the bicep will produce fluid inside the bicipital group. So your MRI finding will suggest bicipital tendinitis, but clinical radiologically patient don't have any symptoms of bicep pathology. So this correlation is very important, and that as Dr. Jahangir has well illustrated that how you should read this, and it's important to read the specific cut because shoulder, as you see, it's a ball and socket of a joint, and your glenoid is usually gets depth by the labrum only, and it's retroverted in 30 degrees. If you see the plane, its plane is not, it's in the two coronal plane. So it's the oblique sagittal plane, which is important to identify the structure, which structures are damaged. And Dr. Jahangir has shown it very nicely. How will you identify and which structure you will see in which coronal cut or sagittal cut? One good thing I would like to suggest, if possible, try to have a CD or MRI finding in your pen drive. That will give you more, because what happened, any MRI institute cannot provide you all the cuts. They provide you the relevant cuts. So if you have a dynamic pattern, you can roll on your computer and you can see, start from anterior to posterior, start from lateral to medial, and you can see every structure. So the DICOM software is there. You can download this software on your laptop and ask your MRI technician to give a CD. They will charge, in India, they charge hardly 100 rupees to provide a CD. And that gives you a really real-time experience of reading the MRI. You can see some minute findings which you can't see in the plate, because what happens, we have limitation in plate. You can't provide 100 or 200 cuts. It's limited to 64 or sometimes 32 cuts only. So when you see the dynamic MRI, the real-time moving MRI on your laptop, you can identify and you can correlate your clinical finding with the pathology which you can see in your MRI. So Jahangir, what is your say on this? Right, regarding having the CD and seeing the MRI in a dynamic view rather than the static pictures. Please unmute, Dr. Jahangir.
Dr. Jahangir, sir, yeah.
Yes, yeah, honestly, most of the time it's static, but a dynamic view in our institution or in my practice, I do not use dynamic. I always see the static MRI.
Yes, and you should start reading the static, and then you should train yourself in reading the dynamic. You just you put the CD or pen drive inside your laptop and you can see.
Yes.
But in that you can see multiple cuts, and that gives you a very comprehensive study of that particular pathological shoulder joint.
Thank you very much, sir, for sharing your vital knowledge with us. And hope our young learners will take this knowledge from you. Thank you very much, Dr. James Jagger, sir. Sir, I would like to say one thing that sometimes we found that the MRI findings, the MRI report is normal, but the patient have pathology there. Then how to manage that type of patient? The patient is saying that my MRI is normal, but you are saying that I have some problem in my shoulder. Then how could I manage that type of patient, sir? Dr. GM Jangir, sir.
Yes. Most of the time, if you see the MRI report from the radiologist, they have sometimes, most of them say that it is normal. But I have already told that we are more advantage over radiology because we see the history and examine the patient. And when I detect this patient is suffering such type of lesion, we directly find this film, this film, and where is the pathology there. So we can detect the pathology easily. So we can easily detect. Sometimes radiologists miss because she see the all the film, but I can targeting this film in which I can see the pathology. And also sometimes my radiologist friend asks me, what are you written to see the in MRI? What are the history of the patient? I also help. And ultimate my goal is when we do I find this, it is a confirm this lesion from history, physical examination, and evict from the MRI. Then I find it is in my next step in arthroscopy. This is also true for the Dr. Rajiv Brahman. And this is I think it is the 100% confirmed diagnostic tool, that is arthroscopy.
Yes, sir. Thank you very much, sir. Yeah, definitely the arthroscopy is the 100% diagnostic tool for any kind of shoulder problems. Thank you, Dr. James Jangir, sir, and Dr. Rajiv Raman, sir, for joining with us and sharing your knowledge with us. Dear viewers, I would like to thank RajTV and Malia CNT Specialized Hospital for helping us to organize this type of program. And I'm Dr. Mahmoud Tanvir Ashraf saying bye-bye to you all, and hope we will connect with you in the coming Friday with another shoulder problem in our Orthopedic Solution Academy. Till then, I'm Dr. Mahmoud Tanvir Ashraf saying bye-bye to all of you. Bye-bye.
You are watching RajTV Jagorone Bangladesh. Please subscribe our channel.